Hello, and welcome to today's Essential Together Huddle. Mrs. Jones, who are your essential care partners? I'm Carol Fancott, Director of Patient Partnerships and Engagement here at Healthcare Excellence Canada, and I'm pleased to be your host today. Please note that this session is being recorded. We are pleased to offer this webinar with simultaneous interpretation. If you would like to hear the voice of our interpreter today, please select French from the interpretation menu at the bottom of your screen. We invite you to use either official language to share your questions, ideas, and comments in the chat throughout today's session. I would like to start by acknowledging that we are meeting on land that has been inhabited by Indigenous peoples since the beginning. In particular, we acknowledge that we are broadcasting this webinar from Ottawa, which is the traditional and unceded territory of the Algonquin Nation. We recognize and deeply appreciate their historic connection to this place and the opportunity that we have to gather here today. If you have not yet done so, please do take a moment to respond to the 3 poll questions on your screen. And please make sure to scroll down. The second and third questions are both there in English and in French. And be sure to click the submit to send your responses to us. And as I introduce our guest speaker, I would ask that you do take a moment to introduce yourselves in the chat box and where you are joining us from today. So it is my great pleasure to introduce Lisa Rafoul. Lisa is the patient advocate at Hotel Dieu Grace Healthcare. She has worked in healthcare and human services for over 25 years, and the focus of her career has been on strengthening partnerships among people who receive support, their families, and the people who provide support to them, finding the balance and common ground for good outcomes for all. Lisa has been the lead facilitator for the Designated Care Partner Program, a plan of action permitting all patients the opportunity to have a support person of their choice by their side to provide support during COVID-19 during this time of pandemic. We also have our producers and offer our great appreciation to them for getting us on the air today, Gina Peck, Sheena Powell, and Kelly Ripley, who are operating behind the scenes today. And welcome to all of you, and especially a warm welcome to patients, residents, families, and caregivers who are joining us today. The Essential Together huddles are intended to be a safe space to share what you're learning about the work that you've been doing and what you've been experiencing. It's an opportunity to connect people who have different roles in the health and care sectors, who bring different perspectives and experiences and come from different care settings, but with a shared focus on safely welcoming back caregivers as essential care partners. So to begin, we are coming to you from Healthcare Excellence Canada, and we are a newly amalgamated organization that has brought together the Canadian Foundation for Healthcare Improvement and Canadian Patient Safety Institute. We have a relentless focus on improving healthcare with and for everyone in Canada. In today's session, I'm going to provide you with a brief overview of our Essential Together program, and then you're going to hear from Lisa about her organization that has developed a set of mutual expectations for patients, caregivers, and staff to safely reintegrate essential care partners back into their facilities. And again, the goal of these huddles is really the opportunity for all of us to share what's happening across Canada and to learn from and with each other. So to begin, what is Essential Together? So Essential Together is a program that has been developed in response to what's been happening during this time of COVID-19, but has implications well beyond this time of pandemic. It is meant to support the safe reintegration of essential care partners into health and care settings during COVID and beyond. And we have 3 specific audiences: that of policymakers, those that implement policy, and those who are impacted by policies. And the focus of these national huddles really concentrates on actions for the implementation of the policy guidance. We do use the language of essential care partner, but we know that different language is used across the country, such as designated caregiver, designated care partner, essential visitors. So how is it that we can safely reintegrate essential care partners? Last summer, we hosted a policy lab that brought together a range of stakeholders, policymakers, healthcare leaders and administrators, patients and caregivers. First, to understand what is that ideal journey for caregivers to safely re-enter health facilities. And based on this journey map, we were then able to co-develop this policy guidance that focuses on two main areas: the identification and preparation of essential care partners, and then their actual entry into the facility. And as you can see on this slide, there are 7 components to the policy guidance. And today we are learning more about develop mutual expectations of responsibilities, of which who are your essential care partners. And that is supporting residents, patients, clients to identify and to designate those who they deem to be important to participate in their care. The national huddles will focus on different elements in the coming weeks. So at the core of the policy guidance and for the Essential Together programming, there are 3 foundational principles. And first is really that recognition and acknowledgement of the essential role that families and caregivers play as essential care partners, the ability to differentiate these roles from that of the visitor, and importantly, to engage with patients, residents, clients, as well as families, caregivers, essential care partners, to implement new policies and practices. So as a program, we want health and care organizations to commit to a call to action. We have an Essential Together tool that supports reflection by organizations on where are they at with the implementation of these 7 key elements of policy guidance. We have learning bundles for each of the elements of the guidance and curated resources and tools. And then we have peer-to-peer learning opportunities like these huddles in place. And we also offer additional coaching for teams to support implementation. So before I hand it over to Lisa now, we're going to look very quickly at the poll results. And so let's take a look at what I have here. We have people coming from all sectors, it seems, long-term care, hospital, and other. And many have in progress or have achieved being able to be aware of the role of essential care partners and be able to identify who they would like to have as their essential care partners at any point in their care journey. And then mostly in progress for question 3, which was the process in place across the organization to ensure the consistent coordination of essential care partners. And again, mostly in progress, some have not started, and there is one that has achieved. So I'm going to hand it over now to Lisa to share with us the work that they've been doing with designated care partners at Hotel Geo Grace. And again, as a reminder, please use the chat box to share your thoughts, your comments and questions, which we will get to after Lisa's presentation. Thanks very much, Lisa, and over to you.
Thanks, Carol. Hi, everybody. I'm thrilled to be here today to share the work that we've been doing at Hotel Geo Grace Healthcare. We do call our program the Designated Care Partner Program, and I'll share an overview, and I'll really touch on how the process for patients choosing their designated care partner and ensuring that continuity and coordination. But after the presentation, very happy to answer any specific questions that you may have. So as we all know, last year, just over a year ago, I say it was an impact beyond belief when the World Health Organization declared COVID-19 a global pandemic. And what did that mean for us at the organization? Changes to our family presence and visiting policy. We had a family presence and visiting policy in place 24 hours a day, 7 days a week. Of course, patients defining their family, or we would define family according to how the patient would. And then we were asked to temporarily restrict visitation and temporary suspension of our care partners. You see that sad face. It was a very, very challenging day, as I'm sure you can all relate. But there were few of us champions. This was not directly personal to me, but I could personally relate. We had a son who had multiple disabilities, and right away I just put myself in the shoes of patients and their family members, and and acknowledging to them that this was very difficult for us as well, more difficult for them. But in some of the design work that I've been involved in, one of the key questions was always, how might we? How might we? When faced with a barrier or a challenge, really thinking about what do we need in place to overcome this challenge. And I was on a mission to ensure that we could bring back our care partners as quickly as possible. So I would start asking the question. If people were saying, well, we can't because of this, or we can't because of that, I'd say, but how might we? So that phrase or that question really caught on throughout the organization. So some of our kind of our catalysts and barriers in asking that question, we noticed that I'll go through the barriers first. There was a lot of fear and uncertainty, and it almost seemed like we went back to that medical model, down to the basics. We're here to provide treatment to a patient, and all that emotional support and the value for care partnership seemed to go out the window. And so how might we reduce fear? How might we respond to people's uncertainty? What do we need to have in place? So the fortunate thing, our catalysts were leadership and champions. Our leadership, senior leadership, we had in place an incident management and response team that really listened to what a few of us champions were saying about the importance of our family presence policy and the importance of essential care partners. There was evidence, Healthcare Excellence Canada, formerly at that time Canadian Foundation for Healthcare Improvement, Institute for Patient and Family-Centered Care, Ontario Caregiver Association, all of those wonderful organizations had documents that talked about the evidence for mutual benefit and partnership. And I started looking for what else is out there. Is there anything that can tell us how to get this done? And I remember there was a document from BC. I'm fortunate to have a friend who works for the government of Canada. So I asked her, as soon as you have information, can you please send it our way? And there was a guidance document from BC that she sent to me, and we really used that as a foundation for starting to build our model. What did we do? We had a working group. We wanted to make sure that the working group was representative of all stakeholders. So, operations, rehabilitation, communications, legal, quality, of course, our patient and family advisory committee, getting together to talk about, what would a tiered visitation plan look like? Again, wanting to engage our staff. What is it that you feel is important? What do we need to get this started? What do you think are some of the barriers? What do you think are some of the strengths? So we did a robust consultation throughout the organization, which helped us also develop the plan. Then we did a presentation to our leadership team, including our PFAC. We went around to all staff huddles to talk about what we had learned from them and what we were planning to put in place, just to get any additional feedback. And of course, we wouldn't have been able to move forward without the ongoing support of our leadership. One of the key things that came out of our consultations with staff and our patient and family advisory committee was that it would be really important to do an information session or some sort of education for people coming in, so that they understood what their role was, why we were doing the orientation, and how they could come in safely, and how we could establish this partnership together. We had our public health unit look over our policy, our guidance document, as well as our plan for orientation to ensure our accountability that we were covering all details so that we would bring people in safely without any undue risk. The orientation is 75 minutes. It includes a review in simple language, our policy, which helps to define, what is a designated care partner? How are you different from a visitor? The benefits of care partnership. What are some examples of things that you may do? And we emphasize to them that even though you're called designated care partner, you're not going to be asked to do you're not going to replace a nurse, you're not going to do any clinical work. You are a care partner, and this formalizes that. It helps them understand their roles and responsibilities. We go through the schedule, the times that they can come in, some of the boundaries, for example, no eating or drinking in a patient's room, where their designated eating areas are. Of course, the ID badge, their picture is taken upon arrival at the orientation, and then we have our coordinator for spiritual care. She creates on a program that she has an ID badge. There is an electronic sign-in. The program, I don't know the technical aspects of it, so any of this information I could absolutely get for you, but I know she calls it Volgistics. It's a volunteer electronic sign-in program so that designated care partners can sign in and can sign out with their ID badge. And of course, their ID badge identifies them as a valued member of the care team. And we do have our patient and family advisory committee on site to co-teach most of the orientations. I mean, some of them they're not able to be here, but most of the time our PFAC members share the responsibility and help to co-teach the orientation. One of the important aspects also of this program is our evaluation. We provide a questionnaire at the end of orientation to get their perspective on the information session. About a month after the person is involved as a care partner, they will get a survey sent to them by email. If they don't use email, we can give them a call. The patient, upon discharge, 3 or 4 questions have been added to the discharge surveys so that we can obtain their perspective and the staff perspective. We had intended to do an evaluation or a questionnaire last November, and then we had our first outbreak. So that was kind of temporarily suspended because we didn't want the results of the staff surveys to be in any way skewed by what we were going through with regard to the outbreak. So we just completed a staff survey about 6 weeks ago. We do have results, very positive. Most staff are very happy with what the designated care partners learn at orientation. They see the value in care partnership, and they offered some suggestions. For example, an orientation onto the unit. So one of our next steps is meeting with the operations managers to say, what does a welcome look like on the unit? Possibly doing a video, a tour of a unit so that care partners know, what to expect when they go on the unit. But I really think that introduction to the unit manager in person is very important. And who will do that? Yes, the unit manager, but also what staff will be involved. Again, to engage that staff, engage the staff to strengthen the relationship between the care partner and the staff team, and of course the patient. So we will do ongoing staff education according to what the evaluation results are telling us. We will tweak the orientation accordingly. We have a designated care partner advisory committee. I thought it was important to have a small working group to advise specifically on designated care partner program. Already we have some feedback. One of the things was in line with what the staff had said, a welcome or a bit of a orientation once on the unit. And we're also looking at some website updates. Our advisory committee has said, you know, it should be a little bit more user-friendly and a little bit more clear about what is a designated care partner and what does this mean. So that's in progress. I've said to our team over and over again, the evaluation will be key. And who's on the designated care partner advisory committee? I have two representatives who have just recently been a designated care partner. We have 4 members from Patient and Family Advisory Committee. 2 of them were heavily involved in the development of our original family presence and visitation policy. And the other 2, or actually 3 of them, are co-teachers of the orientation. And we have operations manager to offer that perspective, as well as a representative from our quality team. And so, you know, what happens beyond the pandemic? So the goal was, from what I'm told, and COVID-19 really helped to move this along quicker. And, you know, we say it was quite an opportunity. It's unfortunate that we have a pandemic, but we've jumped on the opportunity to really establish a care partnership program, you know, caregiver ID. What does it mean? Strengthen that understanding, not only for our staff, but for designated care partners. What does that mean? What is your role? And a designated care partner won't be for everyone. A patient may choose just to have a visitor, and when we're able to have visitation again, you know, they so will choose that. We do ask patients, I forgot to talk about this, we do ask patients upon admission. So if they're coming from one of our regional acute care hospitals, we have provided them with an information sheet about our care partner program, who to contact once their loved one comes over. Patients are asked who they want to be their designated care partner. Most patients will identify someone. Of course, if a patient isn't able to express that themselves, they may have a substitute decision maker or power of attorney. There is a small handful of people who say, I don't want a designated care partner. And that varies between people who are here for a shorter term rehab stay, maybe 3 weeks, or somebody who's here for a longer, slower stream rehab, you know, 3 months. So it just depends, but some will say, I don't want a designated care partner, and that's their choice. We revisit that. The care team revisits that with the patient from time to time just to check in. But we really want to make sure it is the patient's choice, and it's who they designate, and someone that they trust, and someone who can make the commitment beyond a social visit. Right now, we're working on an odd, even schedule. So patients whose room number ends in an odd number, they would come in on odd calendar dates. And those who ended in even, the room numbers ended in even number, come in on even calendar dates. You know, part of my advocacy is, you know, how might we, what do we need to have in place so that people can come in every day? But, you know, of course, I'm sure you appreciate baby steps. And beyond the pandemic as well is hopefully that this program, we also have an inpatient mental health treatment center, and right now they don't have designated care partners, anything formally established, and we hope that sooner rather than later we can support patients who are here for mental health treatment, that they can have designated care partners come in as well. So, that really kind of concludes the formal part. I wanted to give you a general overview. Very much open to any specific questions. I was trying to see as I was going on or presenting. I know there was a question about who's on the advisory committee. If there's some specific questions, I'm happy to answer.
Thank you so much, Lisa, for sharing the journey that you have been on at Hotel Geo Grace. And I really liked how you ended it with the overall goal is really that understanding of strengthened partnerships overall in the health system, and that we know that family presence, the presence of essential care partners, is a very tangible and explicit policy and practice that can support patient-centered care, patient-partnered care in a very real way. And so, interesting how in some ways, I guess the silver lining of this is being able to jumpstart some of this work or to put it into place in very real ways during times of crisis like this. While folks are thinking about their questions and comments, I actually have a couple as you were talking about your experience. It was good to hear how you had talked about that welcoming environment, and from the outset, how staff do ask patients that are coming in, who are their designated care partners. But you had also mentioned through the evaluation, you're thinking about what does that welcoming environment look like? Can you share with us, what is your sense with staff as you've been going through this about that understanding and the valuing of the role of an essential care partner? We've heard lots of different things from folks across the country on this, and just wanted to hear a bit more from you on, did this present as a challenge to you from the outset, or were people very open and understanding of that difference?
Yeah, the original resistance was fear. I remember one of the charge nurses even stopped by my office and said, "Are we really bringing people back? Are we really bringing care partners in?" And I said, "Yep, we are." And she goes, "Oh," and I said, "Well, what are you, obviously it looks like you have some concerns." And she says, "I do. I don't know, we don't know where they've been." And I said, "But the other side of it is they don't know where you've been either." And I said, "There's a fear from both sides." And I said, "We want to ensure that people know they're coming in safely, whether it's staff or care partners." And that's, of course, everybody goes through screening. But we even talk at the orientation about, I say, we can't tell you what to do. We can't tell you how to live your lives, but we want you to be mindful of your responsibility coming into hospital. You're going to the essential places, and we're being asked right now to stay at home and not to visit with people outside of our immediate households. And I said, studies have been done already that every province sees a spike in cases as soon as there's a holiday weekend. And I said, I can't stop you, but I want you to be very mindful of your responsibility. I said, staff are reminded weekly. We have messages from our CEO weekly about our responsibility. And I said, and if you are going to visit someone, wear your mask. I know it's not something typical, but wear your mask. So staff were a little bit resistant about that at first. And our survey results say, the staff say that they understand the benefits and what is a designated care partner. I think there was 75% said they understood. I'm not so sure it's 75%. And that's why we'll do some ongoing education, whether that's attending staff huddles or writing a weekly blog. Those are some of the ideas, or storytelling. We all know how beneficial that is. So that's. Did I answer your question, Carol?
Mm-hmm. Thank you for that. We have a couple of questions from Sonia Green-Haché, and really it's on the journey map that we did in developing the policy guidance and this notion of the developing mutual expectations, part of what was talked about with the group was having a constant point person, so to speak, on staff that the designated care partners, essential care partners, would know who to go to. And I think this points to Sonia's question about, are there specific individuals or positions that are assigned both to identify and to orient the care partners? And then her second question was about your evaluation tool, and if you would be willing to share that.
So we can absolutely share our evaluation tools. For sure. I can send them to, what would be the easiest, Carol? Send them to the folks at yep, and then you can distribute. Absolutely.
Yes.
We do have a few positions. So on the units, primarily it's the unit manager who introduces themselves to the patient and asks them about their care partner. And then we have a system set up. It's on our common drive. So the unit managers, myself, our admin assistant, all have access, as well as screeners, to the common drive. So managers will plug in the patient's initials and the name of the designated care partner, their phone number, and it's color coded. So if it goes in red, then our admin assistant knows that they call that person to schedule them for a designated care partner information session or orientation. I, as the patient advocate, I teach the orientation. And so I would be the point person for any questions. Anything simple, a simple question our admin assistant can answer. If there's something a little bit more complex, they would contact me. And again, that partnership, working with the unit care team, if you know, to help answer the question, or if there's any issues or concerns to resolve that. But that admin piece, having one consistent person, I can't tell you how beneficial that is. It helps to establish a relationship, and the unit managers at first were doing the calls, but those calls can be anywhere from 1 minute to 20 minutes, depending on the how many questions they have, or just their comfort level. So that admin person can really spend some time with people and give them the information ahead of time about wearing a mask when you arrive on campus and where to go and all of that stuff. So we have an Excel document in our common drive that we have access to, and that's how we kind of keep things coordinated and flowing. Right now, I think we have, can I go, did I answer the question, or is there anything else? Sorry.
That was great, Lisa. And I think you're staying on top of the chat box too. So I'll read out the next question, which is from Genevieve David, one of our colleagues from the Center of Excellence at the University of Montreal. So how many caregivers are in your program? And what is the duration of the program or the orientation? And I'm wondering too, Lisa, when you're speaking about the orientation, if you can just give a little bit more insights into what else you're covering. And if it's in person at the time, because you had mentioned that you have PFAC members that are also involved.
Yes. So the orientation takes about 75 minutes, so 1 hour and 15 minutes. So far to date, since last June, I believe June 5th, 2020 was our first orientation session. Since then, over 700 people have gone through the orientation. Now, there's not 700 people on site now. We have about 250 patients, and I think right now there's about 218 active designated care partners. When they're complete, when the patient is discharged, the designated care partner is discharged and they hand in their ID badge. So for the orientation, folks come in, their picture is taken, and that's for the purpose of creating their ID badge. We show, we have a PowerPoint. So, you know, I wanted to make it a little bit more interesting. Teaching a policy is very dry. I created a PowerPoint in more simple language, really helping them to understand, what is a designated care partner. Giving them opportunity to ask questions, but explaining what this means. Out of 700 people, I think we've had maybe 2 who have actually said, this isn't for me, I can't make this commitment, I'm going to talk to my loved one, but right now this isn't for me. So we go through their roles and responsibilities, like screening at every visit, signing in electronically, wearing your mask at all times on campus, and also they have to wear a visor as well when they're inside the patient's room. We talk about confidentiality, respect, a respectful environment, and I say, we would expect respect and consideration for the patient and care team, and that we expect the care team to respect and treat you with consideration as well. If you have any issues, let the unit manager know. Really helping them to understand what this means, that they are part of the team. So sharing ideas. They know their patient, their loved one, they know their personality and their individual nuances, and you can help us get to know them as people. We meet them temporarily as patients, but we want to know who they are as a person so that we can strengthen their care, and that's who you are as part of our team. We talk about some of the things that that their loved one may want them to do, but also emphasize that they don't have to do anything that they're not comfortable with. Talking about keeping the lines of communication open. I offer some tips on communication, that if you do have a concern, talking about that old proverb that you can catch more flies with honey than vinegar, and thinking about how do you want to approach your question, and usually with a question, I was wondering if, or please help me to understand, or I've noticed this, have you noticed that too? And we also open the door that they can give me a call if they want to kind of run it through first before they talk to the unit manager, and that I can also be a support. So we talk about their role a lot. And then of course the schedule of when they can come in and when they can't, some of the boundaries. We have a designated eating area for our designated care partners, and always presenting the why. Why can't you eat in the cafeteria right now? Well, because we have to provide space for our physicians and staff, and when the hospital was built, it wasn't constructed with a pandemic in mind. And throughout, whether it's to designated care partners or staff, I think it's really important to explain the why. And then our infection prevention and control nurses, that there's a team of 4 or 5 who created also a presentation. Usually they come and do the presentation, but if they're not available, I teach it on their behalf. They talk about 4 moments of hand hygiene. They have a video on how bacteria is spread by contact. They talk about the use of masks, the visor. They go over PPE, how to put on, don and doff PPE. Where we have pictures showing folks, this is what it looks like when you come in. This is where you grab your mask, that kind of stuff. So that's a little bit more detail of what the orientation is about, and I can certainly share our PowerPoint. And the PowerPoint is ever evolving. Things change. It seems every 3 months or so. So we just tweak and update the PowerPoint according to what's happening, not only in our community, but province-wide. So it's a living document, so to speak.
Mm-hmm. One of the things that I've noted from what you were saying is also for the families or the caregivers to understand their role as a designated care partner. One of the things that we noticed when the pandemic first hit was the switch in language, though, of, even those places that had recognized, family presence, the importance of that role may have have been called caregivers and not visitors, but a reversion back to the language of visitors. And so I'm wondering what that's been like in your organization, and really curious to hear from others through the chat box what it's been like for any of you and the language that you're using, because I think language does matter, and it orients you in a very different way if everyone is lumped in as visitor versus being able to understand that other role as a designated or essential care partner.
Yeah, for us, that very first day, I remember March 21st is when we had the meeting one evening, and that we were going to restrict visitation. And then signs were made, no visitors. And so there was a few of us who said, but we're starting to use the term care partner. So it took some education on our part. Signs were changed, and slowly, but I don't think we're there yet where everybody in our organization understands the difference, and that will be part of our ongoing education. And even at designated care partner orientation, I say, the typical term you're used to is visitor, and then we talk about the difference. But it is, we had evolved to a point, then all of a sudden, here's the pandemic, and everybody went back to the term visitor. Part of it, I said, the general public identifies with that term. But, again, how might we move toward using or care partners? We have an ethicist, Dr. Hazel Markwell, who's done some work. She even was doing work during the first SARS pandemic, and had written a paper about the emotional harm that patients, how they were affected with the isolation. And she said why we chose designated care partner is she said, we just be careful. We know that care partners are essential. She knew that our goal was, no matter how high our numbers, or with lockdowns or restrictions or stay-at-home orders, she knew that we wanted to continue with care partners coming in. She said, I wouldn't want government or your public health unit to say, well, emotional support isn't essential. So we know that care partners are an essential part of the patient's care. And these are the reasons why. And so, it's an evolution, and Healthcare Excellence Canada, Institute for Patient Family Centered Care, all of these organizations are also being very supportive with their tools and resources. So, we're very much staying on top of all of that, and it helps. I think we're all part of that movement in distinguishing between a care partner and a visitor. So that's been helpful too.
Mm-hmm. Thank you for that, Lisa. And I'm seeing some comments in the chat box as well, with similar comments of working hard to change the language and that understanding that goes with it. So I think that's a nice segue into closing this off and just saying thank you to all for participating in our huddle today, and especially to Lisa for presenting the great work that's happening at Hotel Gia Grace. And we hope that you found this information, this session, informative. So there are some upcoming huddles. The next one will be happening in May. We have had, unfortunately, to cancel the one that was going to be next week. So the next one will happen in May. And you will be hearing more about that and getting more information. You can certainly reach out to us through our website and our email. Please do reach out, and Lisa has kindly noted that she's going to be sharing some information with us, and so we will ensure that we get that out to you as well. And please sign up for our newsletter to learn more about the opportunities and things that are happening at Healthcare Excellence. So again, a huge thank you to Lisa for her excellent presentation. And thank you to all the HEC, the Healthcare Excellence staff, and the interpreters who have made this happen behind the scenes. And of course, a thank you to all of you, our audience, for joining us today. So this does conclude today's webinar, and have a wonderful day. Thank you.
Thank you.